And my thank you to the CSC as well as Dr. James Tam for this opportunity. So this is from an echocardiogram performed in February of this year. You can appreciate parasternal long axis view with an enlargement of the RVOT, thickening of the IVS, left ventricular hypokinesia, as well as a left ventricular apical aneurysm. This parasternal short axis view shows flattening of the IVS in both systole and diastole. We can appreciate moderate pulmonary regurgitation here with no evidence of obstruction. And this apical four-chamber view shows dilatation and hypertrophy of the the right ventricle, as well as enlargement of the right atrium and an ICD wire with thrombus attached. So before we go to a diagnosis here, I'm going to show one more image, and this is from 2008, so 9 years prior to this echo that you just saw. You can already appreciate some changes evident here. We can see that left ventricular aneurysm, which is still present then, and better motion of the left ventricle overall, however. So does anyone think this is just a mere case of dilated cardiomyopathy? Is this ischemic? Is this possibly pulmonary hypertension with RV dysfunction? Is this hemochromatosis, or is it possibly sarcoid? It turns out that this was indeed a case of sarcoidosis. As we already know, it's a heterogeneous non-caseating granulomatous disorder. Sometimes classically thought of as pulmonic in nature, we know that it can involve any organ system. Cardiac sarcoid is actually detected in isolation in many patients, and it can precede or follow pulmonic involvement. In systemic sarcoidosis, geographic variation appears to vary with relation to mortality. In North America, it's reported as many as 1 in 4 patients. It appears less so in Israel, as it's considered to be less than 5% of deaths related to systemic sarcoid. And in Japan, it's thought to be as much as 70%. So small observational studies do report clinical involvement in up to 5% of patients with systemic sarcoid, though retrospective studies and autopsy reports show as much as 70% cardiac involvement in systemic sarcoid. So we can infer from that that there's a large percentage of patients who have a subclinical presentation of cardiac sarcoid. And that also means that diagnosis can be very difficult and symptoms are nonspecific or insidious in nature. There's also no established consensus on what makes a clinical diagnosis of cardiac sarcoid disease. So today I'd like to outline some possible clinical presentations of cardiac sarcoid, present a set of criteria for diagnosis, as well as some potential findings on imaging studies. So back to the case. At the time, this was a 33-year-old female who had bronchoscopy-enabled biopsy-proven sarcoid of the lung at the age of 33 in 1982. She underwent a short course of steroids for therapy, but these weren't tolerated and discontinued. She was otherwise well and asymptomatic until the year 2000, when she began to experience palpitations. So she presented to the emergency department and was actually found to be in sustained monomorphic VT. She was cardioverted and discharged from the ER. She was started on amiodarone, but didn't really have any other follow-up. She continued to experience annual palpitations, but no hospital visit again until 2007. She was again found to be in sustained monomorphic VT, was cardioverted, and sent home. She returned again the next year in 2008 with again another presentation of VT. However, this time she went on to have an echo, which you did see a clip from previously. This was not thought to be cardiac sarcoid at that time. She went on to have an MRI in 2010 for unknown reasons, which showed no abnormal delayed enhancement, an LVEF of 49%, marked but localized thinning of the inferior aspect of the LV apex, and again, no specific evidence of cardiac sarcoid. Her ECG at that time showed frequent PVCs, left axis deviation, as well as possible old inferior MI. At that time, she also had a normal coronary angiogram. So back to 2008. Let's appreciate these changes one more time, and we can see that there's already evidence of changes way back then. This is 9 years ago. So her clinical course, she wanted to have an ICD in 2011 and no further captured episodes of VT. She had PFTs performed showing a restrictive pattern, as well as that final echo that you saw at the beginning of this talk, which, as reported, showed severe RV enlargement and hypokinesia, left ventricular hypokinesis, an RVSP of 68, panvalvular insufficiency, pulmonary arterial enlargement, as well as a trivial pericardial and a more significant pleural effusion. The diagnosis was finally made in February of this year of cardiac sarcoid. So the diagnosis typically relies on a combination of clinical factors as well as imaging. Findings are again nonspecific in a majority of patients, and thus investigations include the following. On ECG, the most common findings are heart block and arrhythmias. Granulomas in the myocardium can become foci, which is why we can sometimes see monomorphic VT in these patients. This is, of course, most significant in younger patients, let's say under the age of 55, without other apparent causes for these symptoms. And again, findings are nonspecific, but we can appreciate either palpitations, presyncope, or maybe nothing at all in some patients. On echo, it's useful for showing the cardiomyopathy, but difficult for proving it to be sarcoid in nature. In patients with known sarcoidosis, echo does have reasonable sensitivity, and we can appreciate in some cases diastolic dysfunction, abnormal myocardial wall thickness, simulated LVH, wall motion abnormalities, isolated aneurysms, and let's think back to what we saw on this patient's echoes, as well as a dilated cardiomyopathy. Tissue can also appear hyperechogenic secondary to granulomatous involvement. On MRI, again, highly sensitive but not as specific. We look for late gadolinium enhancement, and focal changes are most typical. In these cases, we need to rule out ischemic causes of disease, which was done in this patient. And actually, having findings is predictive of adverse events, either symptomatic or not. VT, sudden cardiac death, do appear to be increased in patients within 1 year who have focal findings of changes on MR. Other changes do include valvular involvement, pericardial thickening, and aneurysm formation. So again, we did see that on this patient as far back as 2008. Biopsy is thought to be the gold standard, but this is not a very sensitive test. It also has a bit of morbidity itself. Postmortem studies do show much better sensitivity, but of course are always after the fact. So the diagnosis, there's no consensus on what makes a diagnosis of clinical cardiac sarcoid. There's multiple methods that have been used in the past, and it's usually a combination of imaging and clinical findings. One proposed instrument used probability ratios, this is the WASOG tool, looking for treatment-responsive cardiomyopathy to steroids, reduced LVEF without other explanations, AV blocks, VT, and T2 prolongation on CMR. Of course, this isn't as useful given that it can't definitively make the diagnosis itself. The Japanese Society of Sarcoid made a set of criteria in 2006, which was 2 years before this patient's first echo, relying on either histological-based diagnostic findings. Of course, histology is based on having a positive biopsy, but the clinical findings utilize at least having 2 major criteria, or one major criteria with at least 2 minor criteria. And looking at what this patient did have, she didn't have advanced AV block, but she did have a positive finding of a reduced LVEF in 2010, as well as ventricular arrhythmia, as well as ventricular aneurysm. So here, she would have had a positive diagnosis in 2010. Treatment versus 10 without steroid treatment. We don't know exactly too much about optimal dosing, but we do know that early treatment is better. One study looked at the improvement benefits in patients with a preserved ejection fraction who were then started on steroids versus those who already had a reduced EF under 50%. We found that there was a survival benefit to this as well. So back to the case. Initially a symptomatic presentation with sustained monomorphic VT in the year 2000 and again in 2007 and 2008. Initially thought to be an inferior MI, we remember that she had a normal coronary angiogram, but we did see that LV aneurysm in 2008. And the CMR in 2010 showed localized thinning of the myocardium, as well as an LV aneurysm then. But the diagnosis was not made until February of this year. So this case, I feel, is representative of many patients with cardiac sarcoid. What should we look for? Those under the age of 55 with otherwise unexplained VT or high-degree AV block, symptoms such as decreasing exercise capacity as well as palpitations in the absence of alternative explanations, and especially in patients with known sarcoid disease. They should all have a baseline ECG and possibly an echo based on their symptoms. And if these are nonspecific, proceed to a CMR, rule out cardiovascular disease, as well as have annual physician follow-up. So overall, cardiac sarcoid is most likely underestimated in asymptomatic prevalence and under-recognized when it is present. Diagnostic tools are available and should be used with a high degree of suspicion in all cases. And no imaging test stands alone. Imaging in conjunction with the clinical picture can help make the diagnosis. Patients are asymptomatic until they're not. It appears that, depending on geographic distribution, up to half of patients with systemic sarcoid will die from cardiac causes, including congestive heart failure, sudden cardiac death, and VT. And we do know that treatment is more effective when initiated early on, even when asymptomatic. So that ends my talk, and I open the floor to any questions.
That's great. That's a good job. Thank you very much.